Okay, I think we can get started soon. Welcome, Dr. Answer. Nice to meet you. Okay. 站主任，您这边可以吗？我差不多可以。好，Okay. All right. So, yeah. Hi, everyone. My name's Eric, and I'm part of the Berk Medical Group. And welcome everyone to our Global Thyroid Microwave Ablation Technology Exchange Conference again. It's our first meeting. And today we're going to have two Chinese doctors from China to do a presentation on thermal ablation, and then we'll also have Dr. Kandil from Tulane University to talk about it as well. So without further ado, please welcome Dr. Jiang to do opening address.
Okay, thanks for Baird Medical to provide us the opportunity to have this meeting. Dear professors, welcome to the fourth Thyroid Microwave Ablation Technology Exchange Conference. This conference provides a unique platform for dialogue and collaboration among leading experts, clinicians, and researchers in the field. Together, we will explore the latest developments in the ultrasound-guided thermal ablation therapy for thyroid nodules and delve into the current status and future prospects of thermal ablation for thyroid cancer. In this meeting, we are honored to invite three professors from China and the United States to give the lectures. And also, we are honored to have 8 doctors from the United States to participate in the discussion. We are deeply grateful for the presence of our international friends and colleagues. Your contributions will enrich our discussions and broaden our perspectives. Thanks for your esteemed participation, and we look forward to fruitful and enlightening conference. Okay, so the first lecture.
Okay, so the first lecture will be conducted by Dr. Huang from Shanghai Hospital, China Medical University. Without saying too much, let's welcome Dr. Huang.
Okay. Hello, everyone.
Yep, you can please share your screen.
Okay.
Yep. Yep, we can see your screen. Excellent.
Okay, thank you. Thank you for introduction and good morning, everyone. It's evening in China, so it's my pleasure to discuss and communicate with you online. I'm in Huang, coming from Shanghai Hospital of China Medical University, and I'm a sonographer. So this time I will talk about ultrasound-guided thermal ablation therapy for thyroid nodules from the perspective of ultrasound. First, let's look at thermal ablation procedure. And this Chinese expert consensus from the thermal ablation of thyroid nodules, we can see there is a lot of advantages, including the minimally invasive treatment and has good repeatability and can preserve the thyroid function. But during the procedure, we know a lot of problem we cannot solve. For example, we can not get the accurate thermal field. We cannot get accurate electric field. So accurate evaluation of the ablation range is needed, and the comprehensive diagnosis and treatment is needed. Compare with the surgery, multi-center blood samples, RCT clinical research needed. Let's look at indications about the benign nodules. First is ultrasound suggests the benign nodules. and fine needle aspiration biopsy should be reported by Bethesda System Class 2. All histological biopsy pathology confirmed benign nodules. And second, no history of radiation therapy in childhood. Third, patient request or refuse surgery and clinical observation. Fourth, one of the following conditions should be met at the same time, including symptoms of hyperthyroidism caused by autonomous functional nodules, and symptoms related to the nodules, such as foreign body sensation, neck discomfort or pain, etc. And third, residual recurrent nodules after surgery, or the volume of the nodules increased significantly. And contraindications, including large retrosternal goiters or most of the thyroid nodules located behind the sternum. For those who cannot tolerate surgery and anesthesia, fractional ablation or palliative treatment can be considered. And contralateral vocal cord dysfunction, severe coagulation disorder, and dysfunction of vital organs belongs to contraindications. There is one point we should pay more attention. For the nodules located in the triangle region surrounded by the posterior capsule of thyroid gland, trachea, and esophagus, because in this location, recurrent laryngeal nerve goes through in this place through, so we should avoid the damage of the nerve. About indications of malignant nodules, including ultrasound showed a single nodule with a diameter of less than 1 centimeter, or not close to the capsule, the distance from the capsule greater than 2 millimeters, and papillary carcinoma confirmed by FNA. In addition, no lymph node metastasis in the lateral cervical region, and patient cannot tolerate surgical treatment or subjectively refuse surgical treatment. Contraindications, including suspicious metastatic lymph nodes, were found and confirmed by puncture in the lateral cervical region, and there is a coarse calcification inside the nodules, contralateral vocal cord with lesion dysfunction, and severe coagulation disorders and cardiopulmonary disease. Before we give the patient the thermal ablation, we should complete a preoperative diagnosis, including thyroid function test, traditional ultrasound, and CEUS, contrast-enhanced ultrasound, and FNA genetic test. CT was used to confirm if there is a cervical lymph node metastasis and to give the patient an overall condition assess of the patient. For FNA, if the result report with class 1 and class 3, we should give the patient repeat FNA and molecular test. Let's compare the cytology and the histology. FNA was the first line evaluation of thyroid nodules. It's easy to operate and a safe, minimally invasive method. But the extraction of the cellular components has no tissue arrangement structure. And the pathology was reported by Bethesda System for report thyroid cytopathology and has many influence factors for the result. Compare with FNA CNB core needle biopsy is a complementary and alternate diagnosis of FNA. Its tissue strip were cut and has tissue structure. So the histopathological examination is gold standard and has few influence factors for the result. but CMB has high risk of bleeding, has some trauma. So in clinical method, FNA was used most often, but a lot of factors will affect the result of FNA. So we should to make every step carefully, including the judge, the puncture, smear or liquid base, and observe. During the ablation, we should combine the ablation protocol. For the large nodules, we can use the protocol from deep to superficial, from far to near, and using moving shot method. But for the malignant nodules, we can use fixed method. And after ablation, we should give the patient immediately CUS to determine whether the lesion is completely ablated. For example, this nodule is a large nodule. We can see if we give the CUS, we can see the bubbles flush into the nodules. And after the therapy, we can see the nodules with no bubbles. That means there is a completely ablation. After that, post-operative assessment and follow-up is needed. Related complications and the condition of the treatment should be documented and followed up with CUS at 1, 3, 6, and 12 months of the thermoablation treatment, and once a year of common US scan to check the size of the lesion, whether new lesion, lymph node metastasis, etc. And post-operative thyroid function indicators, for example, TG, TSH needed. Let's come to the second part about the therapy effect evaluation. During the clinical method, we know common thermal ablation method including microwave, radiofrequency, and laser ablation. But energy transmit orientation is different. For the first two methods, the energy transmit is backward, and the laser ablation, the energy transmit is forward. For example, this is the figure. We should put the needle into the nodules. If we use microwave and radio frequency, we should put the tip of the needle near the border, far border of the nodules. But if we use laser ablation, we should put the tip needle in the near border of the nodules, because the energy transmit is in different direction. And the certification range is different. For the microwave, the range is larger, and the radio frequency is moderate, and the laser is smaller. So we can choose different methods for different nodules. This is our system review, and we evaluated the safety and the efficacy of radiofrequency, microwave, laser ablation therapy for T1 PTC, and compared efficacy of ablation between patients with TA1 and T1B, T1A and T1B. The study found that 3 thermoablation techniques were reliable and satisfactory in the treatment of PTC. In addition, the results showed that patients with T1A had fewer side effects than those with T1B. So we get the conclusion that ultrasound-guided thermoablation is a safe and effective therapy method for patients with T1 PTC. But we know during the ablation procedure, we know there is some question we cannot resolve. For example, the ablation range emitted by intraoperative hyperechoic zone is not accurate. This experiment, we use different tissue, muscle, liver. We use different method, microwave and radiofrequency, and different power, 15, 30, 45. We found ablation range and hyper range are inconsistent, sometimes overestimated and sometimes underestimated. That's because the hyperechoic zone is composed of vaporization and disintegration, so the boundary is porous, not clear. When we ablation the nodules near some vital organs, we should maintain the safe distance and reduce the power and ablation time. Now let's look at the points or tips for attention. We know for the triangle region, there is a recurrent venereal nerve, but it cannot be seen by sonography. But there is a nerve we can see, vagus. Vagus nerve can be vary in different position. The ordinary time is just located between the common choroid and the vessel, but it can change to the anterior of the artery or posterior of the artery. Sometimes it can move to the place between the thyroid and artery. If there is a nodules, we should avoid the energy, the heat to damage the nerve, so we can inject some water. That means water isolation zone. It's composed with lidocaine dilution, less than the concentration is less than 0.25%. If the nodules in the anterior, we can inject water isolation into the anterior space between the anterior thyroid capsule and anterior cervical muscle group. If the nodules in the rear region, we can inject the water isolation between the posterior thyroid capsule and the parathyroid gland, longus, colli muscle, and esophagus, and the recurrent laryngeal nerve. And for the lateral space, the same with that. But there is a difficulty in the middle space. For example, the nodules is just near the trachea. We want to inject the water is difficult because there is a suspensory ligament. But this time we can use to press the needle, press the tail of the needle and to make the tip of the needle lift so that we can make the heat far away from the tracheal vessel and the nerve. This example, we inject the water isolation into the anterior space and posterior space, so it's safe. We gave the nodules the thermal ablation, and after that, we use CUS to see nodules was no bubbles flush in. For the follow-up of benign nodules, we focus on volume reduction rate, VRR. We focus on if the nodules shrink and if there is a region of no bubbles flush in. But for the PTMC, because we doing the thermal ablation, we often use extended range ablation, often 2 millimeters larger than the nodules. So we can not focus on the VRR. We often focus on if the nodules is disappear or if there is a lymph node recurrence and so on. For example, the nodules disappear after 6 months of the thermal ablation. Most of the nodules, PTMC, will disappear in 6 months. And the goals of the initial phase of TSH inhibition within 1 year, we should emphasize that TSH level should become less than 0.1 MIU in medium high-risk DTC and 0.1 to 1.0 MIU in low-risk DTC. Let's come to the summary, the ablation of thyroid nodules, including a lot of steps. First is ultrasound judgment and recognition and FNA and the three-dimensional planning. We should familiar with the anatomic structures and give the patient a CUS. After that is evaluated ablative thermal field. So it's including a lot of steps. Thyroid ablation is easy to operate, but it's not easy to do it well because we should get the system knowledge about the diagnosis, treatment, and follow-up about the nodules, about the patient. So we try our best to do it better. That was my report. Thank you for your attention.
Okay, yeah, thank you, Dr. Huang, for your presentation. Now we will open up for a brief discussion before we pass it to the next presenter, and then see if anyone has any questions to ask. So actually, I have if nothing else, I have a few questions here from a doctor who is participating, but he's driving and cannot voice in. So, Dr. Huang, can you go back to your slide? And then I believe it's the one. Yeah,
Okay.
can you go back? Can you share? Yeah. And then back to the second part where you talk about therapy effect evaluation.
Part?
Yeah, and then I think it's the next slide. Yep. So here, I know we talked about the energy orientation and the salutation range. Can you also talk a bit about the safety comparison here for the three different techniques?
I mean, because the energy transmitted direction is different, it's backward in microwave ablation and the radio frequency ablation. So we should put the needle, for example, this is the skin, and we put the needle from the skin to the nodules, and we should make the tip of the needle in the deep position. This side is the thermal transmission, and the heat is from here to this way to the tail of the needle. It's backward. So we want to give the nodules a completely ablation. We should put the heat point in the deep position. But for the laser ablation, the transmission of the energy is forward. It's from this place to this way to transmit heat. So we want to give the nodules a complete ablation. We should put the needle tip just in the near field, and the energy from this way to this way. So it's different.
Okay. Yeah, thank you for that. And also a follow-up on that. So for PTMC or just regular benign nodules, some doctors in the US kind of ask about the dullness of the needle tip. So another doctor asked about, if you will use a different sharper needle to puncture through the skin first and then put the needle in, or would you use the needle directly? 就是您在做这个消融的时候，就是有一些医生他可能会反映本身的一个消融针不够锋利，然后刺不进皮肤。那咱们一般在做的时候，是否有另外一根针先进行穿刺，然后再用这个消融针，还是用什么方法？
when we use radio frequency, we didn't use any knife but we use microwave because the tip is blunt. The tip is blunt, so we should use the knife to cut the skin and put the needle after that.
Okay. Yep. Okay. Thank you for answering. Okay. Anyone else? Please, if you have any question, feel free to ask Dr. Huang. Okay. Then I think that's probably about it. Thank you for your presentation.
Thank you.
Okay. So nextly, we're going to have Dr. Fei from Shanghai, who's also going to talk about current status and future situation for thyroid cancer. So Dr. Fei Jian is from Region Hospital, Shanghai Jiao Tong University School of Medicine. Welcome, Dr. Fei. Yep.
Thank you,
You can please share your screen. Yeah, I can hear you.
Yeah. So, good morning, everybody. Now I'm in Shanghai, and this is the evening of today. So, my topic is the current status and the future of thermal ablation for thyroid cancer. And this thyroid operation have lasted for 100 years, and we should remember Professor Cocker. He's professor of surgery at the University of Bern, Switzerland, and a pioneer in the development of thyroid surgery. And he got the Nobel Prize in 1909. And after that, for about 100 years, we did the thyroid operation day by day, one patient after another one patient. But in recent 10 years, there is a new opinion that's about low-risk papillary thyroid cancer. So what's that? Let's talk about epidemiological features of thyroid cancer. So the first we can see, we can see the thyroid cancer. You can see particularly papillary carcinoma has shown a rising incidence rate in the recent years. And the second, it is gradually becoming the fastest increasing malignant tumors disease in terms of incidence. And the third, the reason may be attributed to advancement in imaging technique, though there is a debate. And the fourth, the majority of new cases involve a small papillary carcinoma detected through routine examination in the dental findings. And also, there are some surgical treatment controversies. And the first, for thyroid papillary carcinoma, what should be the extent of excision, and should it be limited to the lobes or include a more extensive clearance? And the second, generally, the more aggressive the surgical approach, the higher the risk of injury. And the third, temporary or a permanent recurrent nerve injury and damage to the parathyroid glands are concerned. And the fourth are more aggressive surgical approaches beneficial for the patient's long-term progress. And also there are some controversies in post-operative treatment. And the first is thyroid hormone replacement therapy is really, do they work? And the second, should active surveillance replace surgery? And the third, does the mortality rate increase from 1 per 1,000 to 3 per 1,000? So in Japan, someone believes that PTMC can be classified into 3 types. based on biological characteristics and should be treated differently according to this classification. Some type 1 and type 2 and type 3. That means type 1, low risk PMC, and they need no surgical observation. And the type 2 is also low risk PMC. They need surgery plus therapeutic lymph node dissection. And the type 3, that's high risk PMC. And then they need totally thyroidectomy and plus therapeutic lymph node dissection, and also with radioactive iodine therapy and also TSH suppression. So different type of cancer and need different treatment. And also this is a great article that shows us a 10-year follow-up on untreated PMC cases. That is Ito Hospital in Japan, and Kuma Hospital, Professor Ito. In 2010, statistical results indicated that the 5-year and also the 10-year tumor enlargement rate were only 6.4% and 15.9% respectively, and while the incidence of new metastasis was only 1.4% and 3.4%. So that's a great result to show us active surveillance may be effective. And also the 2015 ATA guidelines point out that patients with PTMC who have no apparent invasive of surrounding tissues, regional lymph node metastasis or distant metastasis can be closely monitored instead of ongoing active surgery. And this can show us PTMC active surveillance indications. And in Kuma Hospital, they showed out 4 points. The first one is non-high-risk pathological subtype. The second one is tumor located within the thyroid gland and with no extrathyroidal invasion. And the third one is no lymph node metastasis. And the fourth one is no distance metastasis. And also in China, we add another 2 points. So one is tumor diameters may be less than 5 millimeter, no family history of thyroid cancer. And another one is no history of head and neck radiation exposure during childhood or adolescence. And also we have contraindications in PTMC active surveillance. The first one is high-risk features such like presence of clinical node metastasis and or clinical distant metastasis at diagnosis. The second one is signs or symptoms of invasion to the recurrent laryngeal nerve or trachea. And the third one is high-grade magnificence or cytology. And also some features rendering active surveillance unsuitable, someone like tumors attaching to the trachea and also tumors located in the pathway of the nerve. We read a lot of different lectures on active surveillance. Most of the articles give us a very good results. So the published data on active surveillance for low risk and very low risk thyroid cancer is encouraging. This is 2 important articles, one from South Korea, another from United States. The sample size is more than 400, one is 406, and another is 483. Follow-up duration is more than 3 years. And we can find the initial diameter is about 6 millimeter or 8 millimeter. In United States, the diameter is a little bigger than in South Korea, but we find the final diameter is just same as the initial diameter. That means in the past 3 or 4 or longer years, the diameter of the nodule just the same. And we also can find both in South Korea or in United States, most of the nodule, the malignant nodule, is so stable, and only 5.8% or 9% of the nodules are enlarged. And we also can find some of the nodules, about 4% or 7%, that become smaller. That's very interesting. But in China, we have some changes of PTMC active surveillance. Something like small heights does not equal low risk. There is no conclusive medical evidence that indicates the progression pattern of PTMC is different from other malignant tumors. And second one, the stratification of thyroid cancer risk involves multiple indicators that are difficult to obtain before or during surgery. And the third one is no imaging or molecular biomarkers can currently predict the progression of asymptomatic PTMC, making regular monitoring the only option for assessing tumor progressing. And the fourth one is social or ethical and legal issues. Intense doctor-patient relationships, uneven medical standards, and significant cancer fear among the public. So active surveillance is very difficult here in China. And we found that's also seen in the United States. So in the challenges of PTMC active surveillance, we can find in National Thyroid Center in the past 20 years, microcarcinomas still account for about 50% of all thyroid surgeries. And thyroid microcarcinoma lung surgical cases only account for less than 1% of all microcarcinoma patients. And in practice, many US doctors have not implemented a close surveillance because different reasons, something like fear of failure or increased anxieties. And also, I think as same as the patients in China, and also the doctors, they also have the different reasons to refuse active surveillance. So the operation is maybe over-treatment, and also active maybe cannot be accepted by all the patients, or maybe accepted by the surgeons. Where is the third path? So we can find the thermal ablation. And I would introduce the principle of thermal ablation. The general concept of ablation refers to a treatment method where instead of surgical removing the lesion, the targeted area is kept in place and its blood supply is controlled, leading to cellular and tissue necrosis. This ultimately results in the disappearance or significant reduction of the lesion. Ablation is characterized by being minimally invasive. Ablation can be categorized into different types based on the therapeutic medium, such as thermal ablation, chemical ablation, radiation ablation, and biological ablation. And I like this map very much because through the principle of thermal ablation, in the thermal ablation, tumor cell membrane phase change and fluidity, and also coagulative necrosis, and also apoptosis, and increased active of lysosomal enzymes affecting various cellular organelles, particularly mitochondrial functions. And also we have endogenous tumor antigen effective, but we don't have too much research on the different effects after thermal ablation. And here we talk about the current status of thyroid cancer thermal ablation. And we can find in 2021, we have two major guidelines, one from Europe and one from China. I'm one of the writers for the China guidelines. And then here we can find the basic principle. And then the minimally invasive therapy may be considered for DTC in patients under the following conditions. The first one is PTMC, and the second one is unresectable thyroid cancer, and the third one is cervical lymph nodes recurrence of DTC, both with distant metastasis. And here is the table. I think it's very useful. They give us some key details about indications for ablation. And we can find it from the left side. They give us some factors supporting thermal ablation, something like demographics, maybe the patient have an older age or comorbid conditions, family history without invasive types, and anesthesia riskers, and or refusal of surgery. And in cytology, it must be classical variant of papillary carcinoma. And in the image of ultrasound findings, the nodule must be central location and have clear margins, no contact with the capsule, and isolated thyroid lesion, no evidence of a thyroid invasion. And the technical resources must be availability of professional techniques for US-guided ablation. And there's also some factors supporting surgery. Maybe the patient is very younger and no comorbid conditions or familial distribution. And in cytology, it may be high-risk cytological features, high-risk molecular patterns, and in the image of ultrasound findings, the nodule may be subcapsular lesion and a posterior lesion or near trachea, or have multiple nodular goiter with thyroid malignancy, and also have some evidence of thyroid invasion, something like this. So if you just begin to do the ablation, and you don't know how to choose operation or ablation, maybe you should have look at this table to have the choice. And the second one, we should share some controversies. And in the treatment of thyroid cancer, in recent years, we have a lot of debate with the internal medicine. Some very famous professors, they believe that DTC is a highly prevalent malignant tumor, but the vast majority have indolent biological characteristics and do not pose a threat to human health. To reduce overdiagnosis, current guidelines do not encourage ultrasound screening for thyroid cancer or fine needle aspiration cytology for nodules smaller than 1 centimeter. And also we can find this article. It's published in 2017. It's from Fudan University Cancer Hospital. They shared some experience with re-operations for patients who experience recurrent after thyroid thermal ablation therapy. And the department has treated several patients with cervical lymph nodes metastasis after thermal ablation, all of whom presented with internal jugular vein involvement. Due to the difficulty in excision the lymph nodes after ablation, the patients with unresected internal jugular vein involved may be required staged surgery. And also with the reconstruction using autologous tissue grafts and attempts to preserve as much as uninvolved vein as possible. And for patients with ablation-induced carotid artery involvement, which has not yet been reported, but may occur, The difficulty of resection increases due to the severity of the adhesion. For these patients, the resection of affected blood vessels may be necessary. The risk of neurological complications and the mortality associated with this surgery is approximately 70% and 40 to 50% respectively. Pre-operative evaluation includes CT, MR, DC, and TBO can assist in understanding the tumor size, extent of invasion, degree of carotid artery involvement, and whether the collateral circulation via the villus circle is adequate. These factors aid in planning resection and reconstruction. So many patients or some surgeons believe that if you do the ablation, if we have the reoperation, the adhesion must be very dangerous. So another part is the evidence about the thyroid cancer thermal ablation. And here I share two articles. One is exploring the long-term efficacy and safety of MWA in the treatment of PTMC. So we knew that the effect of MWA is very good after treatment of PTMC, but we are not very sure a long follow-up result. Now, this article is from China, and they give us 41 ablated nodules, and then 40 nodules were completely ablated. By the third, 6th month of follow-up, except for one lesion with significant calcification, all other lesions have been completely ablated. And except for the first month after ablation, where there was a significant increase in nodule volume, the volume of the lesions at each subsequent follow-up point decreased compared to the previous time point. From the 36th month until the end of follow-up, there was no change in volume. And the third one is during the follow-up period, ultrasound examination did not detect any recurrence of PTMC, cervical lymph node metastasis or distant metastasis. And the fourth one is no patient experienced severe pain or obvious discomfort during the ablation process. 2 patients experienced hoarseness after ablation. 1 case recovered within 10 minutes, and the other case recovered 2 months after ablation. So the paper gave the conclusion. MWA demonstrated excellent efficacy and satisfactory safety in the treatment of PTMC during the 5-year follow-up. For solitary PTMC, MWA should be considered as an alternative treatment method and an active surveillance approach. So this article gave a very good results. And also we want to know some comparative analysis between ablation and surgery. And this article and also give us some results, and they have more than 300 patients in ablation, and also more than 300 patients on surgery. They showed us that no local tumor recurrence or distant metastasis was observed in either group after treatment. There was no significant difference in the proportion of patients who experienced lymph nodes metastasis or required salvage surgery after treatment. The p-value equal to 0.062. And the incidence of post-operative complications was significantly higher in the surgery group than in the ablation group. And the p-value equal to 0.03. This is the article from Korea. So totally, I'm think about the question, where is the future of the thermal ablation? And the first question is thermal ablation the first choice for treating low-risk papillary thyroid microcarcinoma? And the second one is how to choose in cases where thyroid cancer can maybe accompanied by lymph node metastasis. And the third question is, can patients with a recurrence after ablation therapy undergo salvage surgery? And the fourth question is, should RFA, MWA, or AOA be used to treat thyroid cancer? Which of these three treatment methods is better? My conclusion is more clinical research are needed to clearly address the above questions. Thank you very much.
Okay, thank you, Dr. Fei, for your amazing presentation. And then now we'll turn to the discussion section and let's see if anyone has any questions. Let me just
Hi, Dr. Fei. This is Linda.
Hi.
I have a question here from Boston. In terms of the cancer nodules, what are the range of the size that you would recommend to do surgery with the microwave ablation? And how long usually it takes to complete a surgery?
That's a very good question. And in China, in Shanghai, or in my hospital, I prefer the thyroid cancer, the diameter less than 1 centimeter. Not only the diameter, both we should judge the position of the nodule in which side of the thyroid gland. And we both say we need the better one is the localized in the middle of the thyroid, not near the trachea or not near the nerves.
Thank you. And also, do you set a special temperature differently if it's normal nodule or the cancerous nodule? Do you set a different time, a different temperature, or it's controlled just by time?
We just judge by time, and also before we did the ablation in patients, we do some ablation in the pig, and we test the temperature, and we need how long we can got the high temperature, and we can get the necrosis of the carcinoma. So we have that experience. So we also have the and how big is the nodule and how long we need to have the ablation. So we did that experience, so we know how long the ablation can make the carcinoma necrosis.
I see. So how long time usually, if you say less than 1 centimeter, will take?
And when in my hospital, about 20 seconds is enough.
I see. So you don't really care or mind to know how high the temperature gets from the needle, right? That doesn't really matter. You just control it by time.
Yes, time is enough.
A lot of the US doctors here are concerning or asking, they always want to know how high the temperature gets of the needle.
And
What,
in my in my experiments, we have the test temperature in the I think in the middle of the ablation, we can test the more than 8 temperature, 8 degree, 80 degree.
I see. So that's the highest highest temperature it will reach.
Yes, and also we test the border of the ablation. They are more than 60 degree.
Okay, that's very helpful. Thank you so much.
You're welcome.
So I think there's another question raised in the comment section. So Kevin asked about the proportion of patients who need to take hormone replacement therapy after ablation. Dr. Fei, do you have the answer for that? Yeah.
Yeah. 你说的是再次手术？
就是做那个，对，再次手术。
In the past past 6 years, we have the more than 1,000 ablation for PTMC, and we have the research, and less than 10 patients got the second operation, and I think it's a good result.
Yes. So over 1,000 cases, about 10 patients will need to do a second surgery. So that's about 0.1%. Okay.
Yes.
Okay, that's a very good result.
Yes.
And then, so I think another common question here from the doctor, and forgive me, this is to common sense for you. So it's about benign nodules. So he asked about, what are the most common complications you have encountered when you treat, benign nodule with microwave in practice, and how did you, mitigate them?
你说良性结
就是良性结节的时候，最常见的这个复发症是什么？然后怎么样去治疗它们？就是您在手术过程临床的经验上来说的话。
Okay, in the benign nodule, the most common complication, the first one is the nerve damage. So the nerve damage, mostly they can recover after 1 or 2 months. And also only 1 or 2 patients that need rehabilitation. And the second one is the necrosis of the ablation nodules. We use some traditional Chinese medicine, and it's very useful for the necrosis and necrosis. And I think the most common complication is just the 2.
Yeah, that's good. It's very good to know, because we see a lot of complications, on papers. But since the doctors here have very little experience compared to you guys in China, so they would like to know what kind of complication would they face in practice. So that's very good information. And I think
I have a question.
Okay, go ahead.
Yes, if the patient have like thyroid gland removal, the patient should take some hormone therapy replacement. But if the patient do like a microablation procedure, after that, how that portion of patient need to take hormone therapy? I want to know the portion.
So I think Dr. Fei just answered that question, and he mentioned that, out of the 1,000 patients he has treated over the past years, about 10 of them will need to take that second time. Yeah. Okay, and
thank you.
Yep.
Thank you.
And
Eric,
then,
I have a question.
Yep, go ahead.
Thanks. This is kind of related to preventing complications. You talk about doing the hydrodissection or the liquid isolation. I've seen sometimes where it's mentioned to use like a combination of saline and lidocaine. I've also seen physicians just use dextrose. And I'm wondering if there's an advantage to using one liquid over the other, and if there's an importance to adding the lidocaine.
Okay, so 就是那个费教授，他是问，就是我们在临床上用那个利多卡因还有盐水，就比方说我们在麻醉的时候可能用那个利多卡因，那有时候在打隔离液啊或其他时候会混盐水。那么美国医生就问，相比于只用盐水的情况，那加上利多卡因会有什么效果？是不是主要就是比方说麻醉啊等等这些？
Okay, okay. It's also a very good question. And the lidocaine only, I will use that just under the skin. If you put a needle into the thyroid, we just need the cell line and not lidocaine, because the lidocaine may be infused to the near the nerves, and maybe the patient will feel some discomfortable, and maybe someone maybe a hoarseness, so it can make you misdiagnose that's the damage for the nerves, but it's the effect of the lidocaine, not the application. So we only use lidocaine just under the skin, not into the thyroid.
Yeah.
Okay,
yeah, I think that's very, very helpful. Because we often see guidelines published in China, and then they suggest different uses, and it can depend on the doctor's habit. But I think the distinction here for superficially on the skin, and then considering not using in the skin, it's a very good way to distinguish it. So I think here is another question from a doctor who's been practicing radio frequency for quite some time, and he's looking into the option of microwave. So he asked about how did you decide between microwave and radio frequency? Is it depending on the size of it, or are they other clinical factors that you take into account?
And myself, I prefer microwave because it's more effective. It's my experiments, we compared both three different ablation, and we think the temperature is much more stable in microwave. That's my opinion.
Okay.
So
yeah, and what about the time reduction? Because some doctors do realize that they're not in the clinical papers looking solely at the time reduction comparison, but they have heard from their colleagues or people who have done microwave saying that microwave takes way shorter time than radio frequency. Does that apply to you? 就是微波比射频时间短，但是呢，有一些医生他现在还没做微波的话，他可能没有看到相关的一些临床的这个研究，但是听说是这样的情况，就想问一下您这边这个是不是也是这样
？Yes, yes, it's true.
Okay. Thank you for answering. Yeah, that's it. Go ahead.
Hi, Dr. Fei. This is Bear from New York. There's some of the doctors in New York mentioned that because they're very familiar with the RFA. So they said it's possible to see the amount of the heat generated in the joules when they are using the RFA in the procedure. But for the microwave, it only displays the energy in the watts. So in your procedure practices, do you focus on the joules on the heating during the surgery, or is there any other way you monitor the range and the condition of the ablation during your procedure?
Excuse me.
就是有一些就是他们用 RFA 的医生，他们会有一个显示屏，可以显示RFA 它产生了多少焦耳的热量。 他们可以监测到，然后不同的热量可能会消融的不同的一些范围，但是微波的话没有这个显示。那我们在临床上是如何监测和去把控我们的消融的范围和它的能量？
Yeah, that's true. In the clinical experience, we judge the border of the ablation. We just see the image of the ultrasound, and the heat can produce many bubbles. And we can see the echoes from the nodule border. So that's according to our experience. And in the IFA, they can show the energy. And I think in my experiments, so that also need more experience to compare the value and compare between the value of the border. That also need more and more experience to know how about the effect of the ablation. And I think if you use one kind of ablation, is very is more and more in more and more cases you can judge it very excise.
Thank you. So it speaks more experience. Thank you.
Yeah.
I think that's a very good question, because a lot of doctors, they were, even though they're surgeons and they have been doing enough RFA cases, but they're still a bit resistant or hesitated to do it by just observing on the ultrasound screen. But as Dr. Fei mentioned, with more increasing number of practice, they should get more used to it. Yeah. So I think a good follow-up on that is that based on your experience, Dr. Fei, how much training or what kind of training would take to do microwave if this doctor have done a few hundred cases of RFA？ 对，就是如果他做过，比方说几百例的这个射频，那在什么样的情况下，你会建议他开始开展这个微波的这个技术？
And I think just to do the ablation, there's not really so much difference between FA and MWA, and as a yeah, that's not too much, because
okay, so
they have the same. They have, I think, after ablation, they have almost the same echo image in the ultrasound.
Okay, good. So meaning if they have done a few hundred cases of radio frequency, they should be comfortable of doing microwave without too much training. Okay.
Yeah.
Good to know. Also, welcome Dr. Kandil, and also Dr. Kazin. Sorry if I pronounced that wrong. Okay, please let Dr. Fei know if anyone else have any questions. Okay. Otherwise, thank you, Dr. Fei, for your wonderful presentation and wonderful discussion. We will stay in touch. Thank you.
Thank you very much,
now,
Dr. Huang.
Yep. Now, I would like to welcome Dr. Kandil, who's a doctor here at Tulane University School of Medicine. He has been doing thousands of radio frequency in the past, and it was wonderful to have him in Guangzhou, China during this past July. And he's now started to practice some microwave and has so far done about 40 cases of microwave. We're very glad to have him here today to share his experience on microwave. And I think this sets a great point for the US doctors to observe the difference between the two from the perspective of one who has done plenty of radio frequency and now shift to the practice of microwave. Welcome, Dr. Kandil.
Thank you. Thank you very much. It's a great honor to participate in this great panel. Do you see my screen?
I might not be able to see at the moment yet. Okay. Yeah, please take your time.
I'm going to try to share again, share screen, and I will do this. Okay, here we go. How's that?
Yep, we can see it now.
All right, sounds good. So again, thank you for participating in this great panel. I look forward to learn more in the future and to watch more of you guys doing these great procedures. So as Eric was mentioning, I was a big fan of RFA, and I'm switching right now. Recently, I had the patient had the RFA and had a recurrence, and the response to the microwave was just amazing. Nothing to compare. So the patient had a couple of RFAs, and the maximum response was like 40 to 50%. And just a couple of months after the microwave, she had like a 70% shrinkage. So that's really impressive. And in US right now, RFA has been on the market for like over 4 years, maybe yeah. So we almost getting into 5 years now. And a lot of these patients, I can tell you, I have a lot of patients that already underwent 2 RFAs by other providers, and they're looking for another alternative. So microwave, it seems like can have definitely a great addition to the field. So, you know, the paper that was published on guidelines for benign and malignant nodules was really a little bit trying to caution on this. I was one of the co-authors on many of these guidelines, but I'm going to just start sharing one of my patients' experience. This is a 50-year-old woman who had 1.1 centimeter nodule. The biopsy showed PTC on the FNA and was interested in the ablation at that time. And as you can see, after the ablation, when we follow her, the volume reduction rate kept going down 5.46%, 9%. And, you know, see the nodule pre-ablation, taller than wider, suspicious. But after the ablation, shrunk all the way to 4 millimeters. I honestly think a microwave in a case like this would be great because it's far away from the nerve territory, and you can do a nice hydrodissection from the carotid. So examining though the the published data, so there is a couple of published meta-analysis, and I have issues with the published data because you know, some of that they just kept repeating the same patient population. Like one group, for example, published 2 papers actually from the Chinese PLA General Hospital in Beijing. And in 2016 and 2020, they had 92 and 174, and they included as 2 different studies. But they, to be honest with you, this is not fair because the 174 patient include the 92 patients. And there is another, the data has 2 versions also that were published. And there are some key differences in between, with the differences in the reported volume reduction rate in one paper was 99.5%, and another one was less than that. And there is difference on the same kind of group. So here is my meta-analysis of the literature, and we did this with my group. So we started screening like 805 papers, and at the end, the criteria that met the inclusion criteria to be included in the analysis were 7 studies. Interestingly, you can see here 5 institutions or 5 papers are from China and 2 from South Korea. So obviously, you guys are the leaders, and we include this is included over 1,500 patients, and over 1,200 of these were women. If you look at the average follow-up is 38.9, and the 38.9 months, which is very good. But if you look later on, the mean age, average age is 44 years, As expected, most of these patients are female, 80%. And looking at the tumors, the maximum tumor diameter, though, is 0.6 centimeter. You see here in US, we are treating a different population. We don't biopsy nodules less than a centimeter. When I had a couple of patients that were less than a centimeter. It's not really the standard of care in US to biopsy nodules less than a centimeter unless you have a lymphadenopathy. As you guys know, these can completely disappear with the ablation. But what's published in the literature, the average diameter is 0.6 centimeter. Well, and then we compared how many less than 0.5 and how many more than 0.5. And as you can see here, 40% were less than 0.5. And so even smaller nodule, like close to half, were very, very small nodules. Looking at the diameter, the average diameter across studies was 99 cubic millimeter. And multifocal disease was present in 2.6%. I don't know how does the group feel about this, but when I see a patient with multifocal disease, I'm worried about this because I'm worried that maybe there is a higher chance that can be metastatic. And how many nodules you are going to follow. But again, in US, we're talking about much bigger nodules, not just one target. And again, multiple nodules. Patients who required repeat treatment were just about 3%. So most patients were appropriately treated with one treatment session. The disappearance rate was almost 99%. I'm sorry. So 99% disappeared with the ablation procedures. The volume reduction rate was, again, 99.8%. So obviously, ablation can make significant outcome. Here is what I want to highlight, though. This is really, I think, the meat of my paper, though. That the difference in treating thyroid cancer is different from benign nodules. In thyroid cancer, it takes longer time to respond to the treatment. And actually, the best outcome is by a year. In benign nodules, you get the best outcome by 6 months. Sometimes very few will continue to shrink up to a year. But in thyroid cancer, they actually start to shrink later. And I mean, I see this all the time. I actually stopped doing ultrasound 1 month after. The first ultrasound will be 3 months after. In the US, we usually do a month after. So we usually do it like at least 3 months after. But I make the patient prepare that this will take time and we should not make any decision before 6 to 9 months afterwards. But this is just really impressive from the published data. Disease progression, meaning the nodule increased or in size, this was just 1.2%. So the outcome is really good. Residual lesions, 0.5%, because we mentioned over 99% anyway, will disappear. Novel cancer development, like another nodule that has cancer, barely less than 1%. And novel lymph node metastasis, again, 0.2%, very well below 1%. It's fascinating. These numbers are actually much lower than the numbers with active surveillance. So most probably with active surveillance, there are bigger tumors. And because I think here, as we discussed earlier, the tumors that were included were the smaller tumors. Again, overall complications that includes minor and major is just 2.4%. And these includes voice changes and neck pain, all this, again, less than 1%. And here is a table to summarize the risk of complication. None of these are major complications. In my opinion, honestly, and I don't know how does the group think about this, most of the complication related to RFA will happen in significantly larger nodules that maybe you can deal with a rupture. Thank God I never had one yet, but or a hematoma or any of these issues. Talking about thyroid cancer, I love this paper. It's actually from the first medical center of Chinese Palais General Hospital in China, in Beijing. And I love it because it's really studies something very fascinating. They looked at over 500 patients, 516 patients with low-risk PTC who underwent ablation, and I followed them for 5 years. The best part is that 65% of these patients are BRAF mutant tumors. My dear friend Mingao Zheng does not think that we should ablate BRAF tumors, but let's look at the data. The data say that, I'm so sorry, I'm in the hospital now, but the vast majority of BRAF positive tumors, and again, they separated the patient according to TSH. As you guys know, historically, endocrinologists used to treat patients with thyroid medication in order to shrink tumors. So they thought maybe we can do this here with RFA. Let's give the patient some thyroid medication to try to suppress the TSH with the hope that this will decrease the size of the nodule. And the follow-up, as I said, for almost 60 months is here. And what they found that the TSH did not make any difference. BRAF did not make any difference. So having said that, I still, in US, we do Afirma testing and we do other like interface that you can check other genes like TERT. If the patient has TERT mutation, I'm not going to play games with this. So if it's a TERT mutation, this patient needs to undergo surgery and ablation is not an option. So here's our Tulane experience with these nodules that are suspicious and cancerous. We treated 110 nodules, and disease progression was observed. Again, the nodules are completely larger tumors, all of them over a centimeter, but progressed in 11.1% of all cases. Regrowth happened in 10% with a follow-up of 14 months. Looking at these data, 49 had a biopsy afterwards. In my practice, I'm starting this new thing where I biopsy nodules 6 to 9 months after to see what happens, because we think we're going to ablate these nodules and see what's going to happen. And the vast majority, 2/3 are benign. 1/3 only continue to be cancerous. And many of these patients are coming from out of town, out of state. So they go to the same place that they did the first biopsy. And the repeat biopsy is benign, does not have cancer anymore. So I just found this is fascinating. No one published this yet. So 28 nodules were benign and 3 nodules disappeared. So ablation of, in summary, I would say 99% of small cancer can disappear according to the published data. Progression will happen in less than 2%. Complication is extremely low, less than 2%. BRAF mutation did not predict any response for treatment or progression, and TSH suppression is not recommended. And I highly recommend that we, as a group, we should start to maybe consider biopsying these after the ablation. I thank you very much for your time. I hope this was helpful.
Yeah, thank you. Hi, I mean, this is a very fascinating discussion for sure, and I can tell that you speed up a little bit, a lot of content to for us to digest. So would you have a bit more time for discussion, or do you need to?
Sure. If you have any question, I'll be happy to answer.
Yeah, so I think a question for me is that I mean, of course, we do this with radio frequency and still not have enough data from the perspective of microwave. But just a brief guess, though, what would you think the result will be? For example, for those different criteria, if we do it with microwave, would they be similar, or would there be any difference?
I think microwave will definitely can have a much better outcome. But from the few cases that I saw while I was visiting in China, that they told me that they still feel uncomfortable a little bit when they go very close to the nerve. I don't know why. I thought they're very meticulously good. So I don't know if it will. I have no idea why people. Maybe microwave is more. Maybe we need to just go down on the power a little bit. But if it's in the middle of the lobe and the superior part of the thyroid, I think I would definitely try to do a microwave, and I think I would have a much better outcome. But with the when it's close to the dangerous triangle, close to the nerve, I would maybe consider just staying with RFA for now. And I don't know how you feel about this regarding microwave with nodules close to the dangerous triangle?
Yeah, because I mean, thank you for your answer first and foremost. The result we have seen with radio frequency, it's it's already good enough. The numbers were very low, the percentage was very low for some of those criteria. So I think it'd be helpful if we do maybe another meta-analysis later on to see microwave effect on this. And then I will show you some papers on this topic if there are any. Yeah.
Absolutely.
Okay. Is there anyone else have any questions regarding this? And by the way, Dr. Kandil also did some 30-40 cases on benign nodules already. So if you guys have any question on that, feel free to ask him. He's not just an expert on thyroid cancer, but also other thyroid surgeries, parathyroid surgeries as well, and also benign thyroid nodules. Yeah. Or maybe could you share with us a little bit on your experience with benign thyroid nodules so far using microwave, and then maybe also using radio frequencies clinically.
Absolutely. I think in my experience, the microwave has a much better effect, at least in the initial stages, from what I've seen. And I expect that for cancerous nodules too.
Okay. And what do you notice to be the biggest difference, or say, the limited effect with microwave? Because a lot of doctors might notice, shortened time, and then higher energy, but some might mention that the VR seem to be similar. Do you have the same opinion, or do you think there are also, other good effects with microwave?
Well, I think with the one of the biggest problems of the RFA, even if you talk to the people who are big proponents, Dr. Bacon Korea, like you really want to go around the vessel, around the nodule with the RFA because of the heat sink effect that does not exist with the microwave. So I think this results a lot better with the microwave, and I've seen that. So I think it's definitely a huge deal with the future for microwave in these cases, because it's just all thermal ablation.
Okay, and so in that sense, it's a bit more stable than radio frequency. Yeah. Okay. Do you find any just very quickly though, do you find anything difficult or puzzled before when you switch from radio frequency to microwave, or it rather like it's a very smooth process, smooth transaction?
Well, I was just fascinating with certain different techniques, like many of the operator does transesmic, but also I've seen other go from the lateral approach. And also, if you talk, for example, about the cystic mass, just fascinating how people treat this differently. Some people just aspirate the whole thing and then try to burn the wall. Some people leave a little bit in order to see the wall and burn it. Some people put some sclerotic material inside before doing the RFA, or the microwave. And I just found it fascinating. There's different ways to skin a cat. But I think what we upon is you need to burn the whole thing. The one thing that's very well I've seen in China, and I try to figure out how we can do this in US, is the contrast study to see the vascularity in the nodule, to make sure it's all ablated. So I'm trying to figure out how we can do this in US. Yeah.
Okay. Can you sorry, I might miss that last part. Can you articulate that a little bit more? So doing one more in the US? Sorry. Okay, we might experience a little bit of technical difficulty here, but that's fine. Hi, Dr. Kendo, are you still here? Okay, can you hear me? Sorry.
I can hear you.
Oh, okay. All right. Yeah. Thank you for answering. And then let's see if any other participants will have any question.
All right. Well,
Yep.
thank you very much, and I look forward for future ones. Maybe in the
Yep.
future we can do actually like a case discussion and panels and stuff like this to discuss certain cases, and we'll take it from there.
Yep. That'll be nice. Thank you for seeing you. And then see you soon.
Thank you very much.
Okay. Take care. Yep. All right. So yeah, Dr. Kandil has been a giant in thyroid surgeries or treating thyroids in general, and then he has done over 1,000 radiofrequency cases, and we do see that the paper he published have some really good results. So for the order of the meeting, now we will go into the final discussion, and then if no further questions, we'll have Dr. Jiang to conclude the meeting. Yep, I'll give you a bit more time. Okay, yeah, if that's the case, yeah, thank you very much for everyone's participant today, and we will also thank you, Dr. Jiang, for staying for so late I know it's very late in China. So, okay, just 1 second. Oops.
Okay.
Okay, yep.
Okay. So now in China it's very late in the evening, but our conference is very hot, and 3 professors gave us the wonderful lecture, and the discussion is very interesting and
Helpful.
helpful. Yeah. So thank you for joining us the 4th Thyroid Microwave Ablation Technology Exchange Conference. Over the past 2 hours, we have engaged in insightful discussions on ultrasound-guided thermal ablation therapy for thyroid nodules, and explored the current status and the future prospects of thermal ablation for thyroid cancer. Your contributions and expertise have enriched our understanding and will undoubtedly advance the field. We appreciate your dedication and look forward to continue the collaboration in improving the patient care. So thank you for your participation, and we hope to see you at the future conference.
Yep.
Okay.
Yep.
Thanks,
Thank you, Dr.
everyone.
Jiang.
Okay.
And then we'll record this meeting and then post it on YouTube. So anyone who's not able to attend right now, please see you later. Yeah. Thank you.
Okay. Bye-bye.